About 17 to 36% of people with narcolepsy qualify for a diagnosis of mood disorder compared to a population rate of about 7%. And people with narcolepsy were about 2 to 4 times more likely to have a mood disorder. Again, this is based on the literature, and there were a wide variety of Okay, there are a wide variety of methodology used, self-report versus semi-structured interview, retrospective, prospective. So it's important to note that when summarizing um, data like that, but the data is compelling. So the obvious question would be, why the difference in prevalence rates? Why are people at narcolepsy more at risk? One theory is that the changes and stressors associated with having narcolepsy contribute to a depressed mood. And we see that people that happens with people with other chronic illnesses as well. And as you know, the challenges and stressors can impact areas such as personal relationships, school and work productivity, and the financial impact that having narcolepsy can have on the individual or the family, just to name a few. Okay. There are also some studies that are exploring the role that hypercretin deficiency, which affects people with type 1 narcolepsy, could play. Researchers are exploring whether this deficiency impedes appropriate emotional input processing from the amygdala, and that's the center of the brain responsible for emotions, emotional behavior, motivation. But this would only affect people with type 1 narcolepsy, and there are some studies that show that there was really no difference in prevalence rates of various psychiatric disorders between type 1 and type 2 narcolepsy. So more research is needed and done in this area, and I know you're going to have some great talks later this afternoon that are going to look at clinical trials of people who are way more knowledgeable than I am on that area. So why the difference in prevalence rates? Um, that would be the question that I would ask. Um, I'm sorry, my slides are just a little off. I got it. We got it all set here. Thank you. Technical difficulties. That's part of COVID life, isn't it? So one challenge is that overlapping symptoms can make diagnosis more challenging because narcolepsy and depression share many symptoms, which can be confusing. And as you can see on this slide, some of the common themes are sleepiness, fatigue, sleep fragmentation, the negative effects on school and work performance, negative effects on socialization, withdrawing from family and friends, weight gain. So when you have these overlapping symptoms, it can make things confusing. And this poses two challenges. One, that narcolepsy diagnosis can initially be missed and misdiagnosed as a psychiatric disorder, most commonly depression. So when someone presents with these symptoms, such as fatigue during the day, sleepiness, maybe interpersonal relationships, difficulties at work or school or at home, since those can be major symptoms of depression, the diagnosis of narcolepsy is sometimes missed and can be delayed for many years. And I'm guessing that there are people in the audience right now where this has happened. There are studies that indicate, in fact, that up to a third of people diagnosed with narcolepsy were previously misdiagnosed with a disorder such as depression. But the opposite may happen. A person with narcolepsy may also be experiencing symptoms of depression, and the symptoms get lost in the shuffle, again, because they are so similar. Then the opportunity for diagnosis and treatment are missed, and the focus is solely on the management of the narcolepsy as a way to address all the symptoms. It's a difficult challenge. So, good news is that you can be your best mental health advocate. And so my main goals for the rest of the talk are to really discuss in depth the symptoms and signs of depression and the importance of being mindful about how these signs may be affecting your everyday life. And as we go through these symptoms, you may sit there and wonder, this sounds a little bit like me. Maybe I need some additional help. And so I want to then provide an outline of how you can move forward. Now, along with this, of course, is the importance of continuing to managing your narcolepsy. And I know that you got good tips this morning about that, and you'll have more this afternoon, because by doing that, you're obviously improving your health and your quality of life, but you're also directly addressing some of the overlapping symptoms. So with this talk, I'll be talking about the first 3 points on the slide here. So before I start talking about depression disorders and the symptoms associated with them, I want to take a moment to differentiate between depression and sadness. All of us have had and will continue to have periods of sadness. It's just a part of being human. Sadness, though, usually responds to coping mechanisms. So if you look on this screen there, you know, talking to others, some distraction, which I'll talk about later on. Sadness is often linked to something. So if someone asks you why you're sad, you can often tell them why, and it usually passes with time. So I don't want to pathologize the human experience. Again, it's part of being human. But significant sadness coupled with other symptoms can turn into depression without us realizing it. The other important thing I want to distinguish is depression from grief. With grief, the predominant feelings are emptiness, loss, and grief is likely to decrease in intensity over days or weeks, and the feelings may occur in waves and often associated with the thoughts and reminders of that person. And grief can sometimes even be accompanied by positive emotions and humor that are uncharacteristic in the pervasive unhappiness and misery associated with depression. And so again, if you have occasional sadness, mood, there are natural mood elevators that probably many of you use and talked about today. I'm definitely big on exercise, although I work with teens, I hesitate to use that word. It definitely has a connotation sometimes. For me, anything that gets your heart rate up and your breathing up. So if you like to go to the gym or something like that, fine. If you like to pull the shades down and dance in your house to 80s music, I'm with you actually, and do that too. But these are examples of ways to manage normal stress, normal sadness, and also maintain good mental health. But these tools alone would not be a replacement for treatment if the sadness turns to much more serious symptoms. And that's what I'll be talking about in the next several slides. So it can be hard to tell sometimes how exactly you feel. So here are a few things that you can look at to indicate whether or not that what you're feeling may be something more than sadness. One would be frequency. So if you're experiencing these feelings often, especially if they have been around for maybe then a few weeks, that would be a sign. Also, if there are other physical or mental symptoms, in addition to just feeling sad, are present, which I'll be talking about in the next several slides, and especially if they don't seem to get better with time. I did want to take just one slide and single out something very important, which is thoughts of self-harm. If you're having thoughts of self-harm, you don't need to wait or examine other symptoms. You likely will have them anyway. You're encouraged to seek treatment. Don't ignore these thoughts. And if the thoughts have progressed into a plan and you think you may act on that plan, you don't want to just be thinking about seeking treatment, or maybe I'll schedule something next week or call someone. You want to act now, calling 911, local emergency numbers. I put several numbers on the slide here, suicide hotline, or go to your nearest hospital or emergency department. And if you can, tell someone that's close to you, and so they can assist, maybe take you to the hospital, things like that. Again, if you have a plan to harm yourself and you think you're going to act on it, take care of that immediately. And that's different, I think, from all the other symptoms. All right, so here is a list of major depressive disorders as categorized in the Diagnostic and Statistical Manual of the Mental Disorders, 5th edition. That is quite a mouthful. And You can see I stumbled over it because I really don't ever say it. I say DSM-5, and that's what I'm going to do for the rest of the talk. It's a manual that's produced by the American Psychiatric Association. The first edition was produced about 60 years ago, and it gets updates, 5 actually. And it's a classification system of mental disorders and associated criteria designed for mental health specialists to just facilitate a more reliable diagnosis. It's not the only manual that's used. The WHO produces the ICD-10, but for today I'll be referring to the DSM-5. So we're going to be talking about the first two on the list highlighted in purple there, major depressive disorder and persistent depressive disorder, or otherwise known as dysthymia, as those are the ones that are the most common. So my idea behind learning about these symptoms is not that you have to or should try to diagnose yourself. That's not the purpose of today's talk. It's really to gain a knowledge and become more mindful and aware of how you're feeling, what to look for to determine if maybe you need help. Yeah, self-diagnosis is not a good thing. I know I recently had something with my toe, the toenail, it just was looking weird. And I thought, oh, I know what this is, and went to my doctor. And I'm like, I bet it's this. And the purple pill, I saw it on commercial, right? We got it. And he's like, no, slow down. We got to do some tests. And in the end, it was just kind of a chronic injury to the nail. Went to another doctor, got it fixed. So self-diagnosis from someone who knows that you shouldn't self-diagnose. So today is just about getting knowledge and knowing what to be looking for and what questions to ask yourself. And we'll talk about how to get treatment if you need it later in the talk. So major depressive disorder, or MDD. So the first two symptoms are the most common. Depressed mood most of the day. And this could be either you saying that or people are telling you this and you agree with them. For children, the depressed mood or sadness can actually be irritability, and children can be diagnosed with depressive disorder. The DSM-5 doesn't really provide a cutoff, but I'd say it could be as low as 4 or 5 years old. But it's a lot trickier because a lot of the symptoms reported will be coming from a third party, like the child's caregivers. So as we're moving down, diminished interest or pleasure in most activities, and these would be previously ones that you enjoy. Other symptoms, as you can see on the slide here, unintentional weight loss or change in appetite, either insomnia or hypersomnia, psychomotor agitation. So that'd be like pacing around the room, tapping toes, rapid talking, or the opposite, which would be psychomotor retardation, like slowing down of thoughts, a reduction in physical movements, fatigue, loss of energy. And as you see, most of these say every day or nearly every day. And so that's really one of the main hallmarks of depression versus sadness, is that these feelings don't seem to necessarily come and go in waves. They just really seem to be there and kind of permeate daily life. The remaining symptoms, feeling of worthlessness or inappropriate guilt nearly every day, difficulty concentrating, making decisions. Maybe you can make a to-do list, but you can't figure out where to start, so nothing seems to get done. And then the thoughts of death and self-harm that we talked about before. So in the interest of diagnosis, what a mental health specialist does is considers the several factors. One would be the number of symptoms. So I listed 9. You definitely don't have to have all of them. And most people wouldn't have all of them. So the specialist is going to look at number of symptoms, length of time that the symptoms have been present, and specifically if they represent a change from the previous functioning. And if they do, what is it impairing in life? What part of life, either social, maybe work, school, important areas of functioning. And if the symptoms, and this is really important for the talk today, are not attributable solely to the physiological effects of a substance or a medical condition like narcolepsy. So you see with depression, therein lies kind of the challenges because of that overlap of those overlapping symptoms. Then there's the second one we're going to be talking about today, which is persistent developmental disorder, or PDD, or dysthymia. So this is more of continuous or long-term forms of depression, just kind of like feeling sad or down in the dumps, maybe not as severe as the major depressive disorder, but it could be at times. And it feels like it's really part of the everyday experience, to the point that some people don't even really notice or report symptoms unless they're prompted to. Just because the challenge is they've just felt this way for so long, it's hard to have a framework or a reference to remember what it was like to feel another way. So this is depressed mood most of the day for more days than not for at least 2 years. And you know, it's not to the date, it's just kind of an estimate. So you can see this is very different from the major depressive disorder, yet many of the symptoms are very similar. Losing interest in daily activities, feeling hopeless, poor concentration, having low self-esteem, feelings of inadequacy. And again, these symptoms have lasted for years and significantly interfere in parts of your life, like relationships, school, or work, daily activities. And again, just like with the major depressive disorder, it's really important to distinguish this from just the medical condition like narcolepsy, or explained by another disorder. So as with major depressive disorder, psychologists or other mental health or maybe even medical providers are going to take a number of factors in, and this is where that intake interview happens. How many symptoms you present with. And again, you don't have to be present with all of them, especially if it's causing a change in functioning. And again, considering that it's not solely attributable to like symptoms of a medical issue such as narcolepsy, and not to another disorder. So at this moment, you might be sitting here right now and feeling like some of these symptoms sound like me, maybe. That does not mean that you're clinically depressed. We're just talking about symptoms, right? This is purely just kind of a screening, just to get you to the next step in the process. Think about it kind of like a medical screening tool. So if you had your blood pressure taken at work, at your doctor's office. High blood pressure alone doesn't mean that you have heart disease. It's just one way to kind of guide you and the provider to the next step. But if you are wondering, and again, or you could be thinking of someone else too, maybe I should talk with someone. I need, maybe I need some help. I'm not sure. I want to take the rest of the talk to kind of walk through practically what you would do next. Like, who do you go to, right? So I think one of the easiest steps would be to make an appointment with your primary care physician if you have one. As you can see on the slide, it's likely an established relationship, and many PCPs do a depression screening as part of their appointment. And in fact, some of them have mental health professionals like a psychologist, psychiatrist, master's level social worker already embedded in their staff that could meet with you. So that's one option. So you're sitting here, you really are thinking about the symptoms and maybe I should talk with someone. That's could be one first step. Another could be to contact your sleep disorder center because some of the disorder centers have mental health professionals on staff. I do think that that's more common. So that's what I do in our sleep disorder center at the Children's Hospital here. I think that's more common with kids than it is adults, but some sleep disorder centers may employ mental health specialists, and that would be a great option. Um, but you could also schedule an appointment directly with a mental health provider, which is not only a great next step, it's a wonderful next step. That's what they do, right? It's just likely going to be harder if you do not already have an established relationship, because depending on where you live, especially, um, the demand outweighs the supply, and you may just have difficulty getting in or getting in a timely manner. Now, I think telehealth has helped with that. Um, we'll have to see how long. Hopefully, the insurance companies continue to support that, and you continue to see a lot of the telehealth being done. So that's kind of why I recommend thinking about your primary care physician, because it's a practical way to just get the foot in the door and be able to talk with someone initially about what you're feeling. Now, before you go to any appointment, you might want to consider taking a depression screener. I don't know about you, but sometimes when I go to the doctor's office, okay, I know what I'm going to say, and I know I don't want to forget to say this, this, and this. And then on the way home in the car, I realized I forgot two things that I wanted to say. So, depression screener can help you organize and remember the symptoms that you're experiencing, and it maybe even might help you think of other ones as well. So one of the ones I like on the screen here, I'm leaving this up, so if you want to take a picture of the link, is the Mental Health America Depression screen. And it's based off of the DSM-5 symptoms, actually. So you just go through the screener, and in fact, it'll ask you frequency, which generates kind of level of symptomatology, maybe mild, medium, severe. Again, not as a diagnosis, but just to kind of give you an idea. But it's free, it's reliable, it's based on research, it's well organized, and it's something then that you could print out and have in hand when you see a doctor or a specialist. Again, I feel both professionally and personally that the doctor patient or the medical uh, whoever it is, specialist and patient relationship is a partnership. So the more information that you can provide your providers, I think the better care that you likely get. So if you feel at that point, now it's going to depend on who you see. So if you went to see a PCP and the PCP says, you know what, I would say based on the screening, it would be worth you talking to someone about this, or moving to the next step. Um, or if you went straight to a mental health care professional and that came up. Um, the next step would be then to decide what treatment you're interested in. And with mental health, there are really two main pathways. There's the medication treatment option, and as you can see on the screen here, that's going to be a psychiatrist, psychiatric nurse practitioner, PCP, versus the psychotherapy option, like a psychologist like myself, licensed professional counselor, licensed clinical social worker. And so you'll see these letters after their name, LPC, LCSW, PhD, to name a few. And the American Psychological Association did a position paper last year with a expert panel really looking at the literature to see which treatment they would recommend, and really the literature supports both. Often, or supports either, but often I've seen anecdotally that people will pursue both. Sometimes with depression, a combination of psychotherapy and medication is effective too. So this would be the discussion. Again, if you went to your PCP, they're going to refer you to someone, and you have this discussion. Or if you went to a mental health care specialist first, that's the discussion that you have. And so those are really the two main pathways for treatment. Well, three if you do them both. But it can be tricky to kind of figure out, well, people have different training. So I really like this website from NAMI, the National Alliance of Mental Health. So that the link to this page I put there if you're taking photos. Otherwise, you can just type in NAMI, types of mental health professionals, and if you search that, it's going to pop up first in the search bar. But I recommend taking a look at this because it provides brief explanations of each type of mental health care provider, their training, and we'll talk a little bit about that. I'll talk a little bit about that more in a second. But it just gives you an idea of, now for our viewers outside of the US, I think the professionals are going to be named a little differently, but the categories are similar. So again, if you went the PCP route and you need to find a mental health care provider, so you're not already attached to one. In fact, if you decided to do the mental health care route in the beginning, so this process would be what you would use as well. How do you find one? And I really thought about this, and I tried to think about what I would do, and so honestly, I like the first step to be word of mouth. And so your PCP might have a few providers that he or she recommends. The sleep team, and they probably get this question a couple times. They may have a few providers as well. If you're comfortable talking to friends or family, someone that you trust, that would be another resource. If you wanted to keep this personal, obviously, then you wouldn't do that. But that would be one place to start. Good word of mouth from a trusted resource. You also, if you have insurance, would want to consider calling your insurance company and then getting a list of providers on your panel. And I think you're probably all aware of doing that for other medical needs. But and then in a perfect world, you'd hope that the panel and the word of mouth recommendations, that there's some overlap between the two. You could also do an online search. So psychology.com is kind of like a directory of therapists with different backgrounds and different training. So the therapist places a bio on the website, and it tells you a little bit about themselves, what they specialize in, maybe even their background, a link to their website. There's no ratings on psychology.com. And the information that's on there is provided specifically by the mental health care provider, kind of like the yellow pages, but no one knows what that is anymore. So I feel old. If you're looking at online ratings, I would be careful, especially if the provider only has one or two, because a really good score or a really bad score could bring that score up or down. I don't think that people are required to prove that they were an actual patient. You just want to be careful that the data that you're using to make a decision is accurate, right? So I would, you could find one maybe where someone has a lot of ratings, and maybe you use that as one data point as you're trying to make the decision. But I would not base my decision on a mental health care provider based on online ratings. One exception would be that if you have ratings that are provided by the medical or mental health provider's place of employment. For example, many hospitals, including mine, solicit ratings from the patients and families, and then they, like on a number system or star system, and then they make these averages public on their website. So at least they're verified. You can trust them. But again, even with this, it's an important decision, and I wouldn't base it just on ratings. Well, what else do you base it on? So one thing you'd want to look at is licensing and training. Looking at the time here. For psychotherapy, you'd want someone with a master's level or higher in fields such as psychology or counseling psychology. And that slide, a couple slides ago, where I listed out several types of providers, all those providers would have had to have a master's level or higher. And again, there are other types of providers too. I didn't list them all. With someone who is prescribing a medication, they need to have MD, DO, PMP. In some states, psychologists can also prescribe psychotropic medication. And then you just have to consider practical issues, right? Location. I mean, you may find a great provider, but they're 3 hours away. And if you can't do telehealth, is that practical? Probably not. Are they taking new patients? Scheduling or availability, in network versus out of network, obviously can make a big difference, and copays add up. Um, Now, let me back up to the licensing training. There are a number of other specialties that can be really helpful in general, like life coaches or life counselors can really provide some great information for general life issues. Um, when it comes to clinical depression, though, I think you want someone who can specifically say that they were trained in that, and that would include practical training like an internship or fellowship. Um, so that's what you're looking for there. It's not that the other providers aren't useful in many ways, but specifically for something like depression, you want someone who is really experienced. And finally, whoever you pick, you're definitely going to have to tell them how your narcolepsy affects your life. I would never assume to know because you all are different, and it's going to affect everybody differently. But you might even have to educate them a little bit on narcolepsy itself. Now, I don't mean like prepare, a 25 panel slideshow and hand them a tablet to take notes and that there's going to be a test after, like nothing like that. But you may need to inform them a little bit of how your narcolepsy affects your daily life, and especially being aware that, again, narcolepsy and depression have those overlapping symptoms. I'm just saying this because it's probably going to happen, that you'll probably have to add a little bit of education unless you got really lucky and had a mental health specialist who is also an expert in sleep or narcolepsy. And that's okay though, because I don't want that to stop you from picking someone. Your main priority should be someone who's an expert in depression. That's what you want to focus on. The narcolepsy component is very important, but that's a piece that can be added. So I'm not a social worker. We have two in our department, and they are wonderful, and I am so appreciative. So I'm not really good at finding people resources, but I did want to add, if you don't have insurance, at least in the U.S., this national helpline, one of the goals of this line is to help families with referral ideas. And generally, what they do is just look at, from a geographic standpoint, where you're at, and then tie you into local numbers to get you started on that process, to find services that are either free or low cost. University counseling centers are another place to get low cost mental health care. That's where, when training, that's where I first started, and they're really good. So that's another thought. So I'm approaching the end of my talk, and I am going to completely shift topics. It's an interesting strategy, really, but so you see what I mean. So anxiety disorders and narcolepsy. We're not talking about that today, right? There would be no way to, I think, thoroughly cover both in a 30-minute span, and I chose depression because it just has a higher frequency rate. But if you look at this slide, two, there's definitely a higher risk when you have narcolepsy of having an anxiety disorder. And it's an increased risk. The reason why I'm putting this up here, though, is because fortunately, the practical part of my talk, where we talk about, okay, I think I have some symptoms, what do I do next? You can apply this to any disorder. So all that information, you would do the same thing if you felt like you had some concerns about anxiety. But to get you started, again, knowing what those symptoms are, I know we didn't discuss those today, and that's, again, just beyond, obviously, the focus of this talk, but I really like this web page. It's from the Anxiety and Depression Association of America. I'll leave this up for a few seconds. They have it's ADAA, and they have a screening tool that breaks it down into the different anxiety disorders. And so, like, for generalized anxiety disorder, over the last several months, have you continually worried or anxious about a number of events or activities in your life? I know right now with COVID-19, a lot of us could answer yes. But so you answer yes, and it brings you to a screener, again, researched, reliable, and like the depression screener, it'll give you some idea of the symptoms, and it's something you can print out and take with you. So I didn't want to just, I thought it was too much of an opportunity to not put it in. And again, I just zipped another topic in at the end, but really you can use the same process that I talked about in trying to get services with anxiety or anything else. So, in conclusion, most people with narcolepsy don't have a comorbid psychological disorder, but they're at a greater risk for depression and some anxiety disorders, and they share several symptoms. So it's really important to focus on all the symptoms so that one area isn't masked. But you, in the end, are your best mental health advocate. And the goal is to just be mindful of how you're feeling. So if you know mindfulness, it's being in the moment, right? Being in the moment without judgment. We're really good at distracting, and days of distraction's great, but after a while, you start to really kind of notice how you're feeling. So just stopping and really thinking about something like, wow, I've noticed that I haven't really returned anyone's calls or emails for a week now. I wonder what's going on with that. Just taking the time to, you deserve that, to give yourself, to be able to determine, hey, this might be something more than just feeling down. Here are some resources and websites, and as we take questions, I'll put up my references pages in case anybody wants to take a photo. All right, there we are.
Thank you, Kevin. That was really informative and really filling a gap there, I think, for people in our community who are struggling with depression related to narcolepsy. And on that note, we do have a few questions, so I'll just jump straight into those while you keep that on the screen. Super.
Great.
Okay, so how does fatigue play into narcolepsy and depression? Many times my depression is related to fatigue and exhaustion. This can sound like depression, but how do you tease out the fatigue from narcolepsy? Especially, I should add, especially if antidepressants have not helped.
So if antidepressants have not helped, that means that someone is prescribing those, and that means that you're working with someone, whether it's a someone on the medical end, or you also have a therapist and you're working with someone. So this is around. So the first thing I would say is you want to have that conversation with the person that you're working with, right? Because that is a wonderful question. I would say the way I would tease it out is I would look at mood, right? Because sometimes I'm fatigued, I'm tired, but that doesn't always mean that I'm not in a good mood or not even happy. I'm just tired. So I think that the way I would tease that out is look at how you're feeling from a mood standpoint when you are fatigued.
Okay, thank you. What are some ways to be proactive in combating or offsetting depression in a child with narcolepsy? And this is from a parent caregiver standpoint.
Mm-hmm. So definitely the mindfulness piece, right? You want to, for lack of a better word, keep your eye on how they are and how they are doing, and look for trends. I mean, that's really, when we're talking about the human experience and talking about sadness here or there, and remember with kids, it can be irritability too, so we include that in there. We're really looking for trends. So you're looking for not just a day here or there, but you're looking for days or weeks where you're concerned about their mood. It's really a mindfulness piece, because we are good at, as humans, is to get used to anything. I mean, we're resilient, so I would say keep track. Maybe you just keep a little journal of just basic kind of mood, and remember that includes irritability. And the main thing you would want to look at is length of time. If you feel like it's something that seems to permeate every day and it's been going on for a while, that's when I would start there, and that's when I would want to seek help.
Thank you. I think we have time for one more. Besides depression, are there any other common mood disorders that present commonly with narcolepsy?
Well, I would say besides depression with mood disorders, I mean, so depression there are many, as you saw back on that slide where I showed the depressive disorders, there are many different kinds. I would say besides depression, that anxiety disorders are actually
Mhm.
the next highest. So I think with depression, the two that I covered are the main presenters. I would say if we're looking at the next concern, it would be anxiety disorders.
Okay, thank you. I really wish we had more time because we do have more questions. But as I said earlier in the day, these sessions are being recorded and will be accessible to our community on our website at
Oh, good.
www.wakeupnarcolepsy.org. Dr. Smith, thank you for your time
Wonderful.
and for sharing this incredible information with us.
Well, I appreciate it. I enjoyed it, and I want to thank everyone. COVID-19 doesn't bring too many good opportunities, but to have a chance to talk with everyone today has been wonderful. So thank
Yeah,
you for your time. Be well.
thank you. Okay, you too. Thank you.